back in the day, we didn't really think about obesity as a disease process, right? This was only until 10 years ago where in the medical community it started getting coined as a disease process. And I think really started treating it that way. It's like saying that if we treated someone's blood pressure and it was normal, we should stop the medication. It's normal because we're on the medication.
My biggest clinical concern, and a lot of people's clinical concern, is muscle loss is a big thing. Oh yeah, obesity is bad. You know what's worse? Sarcopenic obesity, way worse.
I think it's biology and not blame, right? I don't think we would tell anybody if their cholesterol was too high and they're on cholesterol medication that they were a failure. So why should we do that with weight management? I think it's really important for patients to know that it's not their fault.
Welcome to Medicine Redefined. I'm Dr. Ultama Shraja.
And I'm Dr. Darsh Shah. Let's put the health back in healthcare.
If you're a high performer who wants a clear plan for longevity, performance, and staying active with fewer setbacks, I'm now seeing patients through my telemedicine practice, Refining Health and Performance. I'm opening a limited number of founding member spots at refininghealthrx.com. All right, let's jump in. Dr. Priya Jaisinghani. I am so excited for this conversation. And I was thinking about this. I was like, is this actually true? Because I think I told Darsh 2 days ago, we had another recording where I was so excited. I was like, man, this might be the podcast that I've been most excited about since we've done this. And try to put recency bias aside. And of course, I don't want to be disrespectful to the 160 guests we've had on here. It's just that this topic, I think, it's been a long time coming. Just you and I had connected last year. But this is, I think, we're late to the game when it comes to that. And so I'm excited to get right into it. But I think that it probably makes sense for the listener to understand a little bit about your background and kind of what brought you here specifically in this area of interest. So give us the short version, if you want, of your origin story and why you're here passionate about this topic that we're going to talk about.
Sure. So I'm Priya Jaisinghani. I'm an endocrinologist and obesity medicine specialist at NYU. What brought me into this field? Well, I'm the first doctor in my family. I'm first generation here. And I really saw that some communities are very much affected by a lot of metabolic conditions, whether that was diabetes, heart health. And I saw it in my own family, and I really wanted to contribute to providing care to this population who was being ravaged by these disease processes. So that's kind of what led me towards endocrinology. And I did my training at Weill Cornell and New York Presbyterian. And then I also did an obesity medicine fellowship. And then now I'm at NYU as a clinical assistant professor.
And you've always been on the East Coast, right?
Yeah.
Awesome.
I've been kind of local on this side. So I'm an East Coast gal. So grew up in Jersey. And then haven't trekked out much further.
Yeah. I mean, Jersey is the best. Why leave any further? Well, I guess now you're closer to New York. But so metabolic health, I think that's super important. Depending on who you speak to, some people will say it's really all comes down to that. Actually, with, again, our recent episodes, a lot of people have talked about the role of metabolism in areas within medicine that you wouldn't think otherwise, right? So we're talking about psychiatry, we're talking about other parts of the brain. And what we're starting to learn about is insulin resistance and metabolic ill health is oftentimes the quote unquote root of a lot of these causes, the issues that we're struggling with. Yeah. And that's why I think that when we're talking about obesity and GLP receptor agonists, like it's been so profound. And we're going to touch on some of the literature with respect to their benefits in a variety of ailments. I think though it makes sense for the listener, just so that they have an understanding that there are other things out there aside from GLP-1 receptor agonists. So would a brief history of just anti-obesity medications, AOMs for short, and like how we got to this generation of GLP-1 era. Again, important. There have been multiple generations. These have been around. Can you give a quick primer on AOMs and, what you think is worthwhile and if you're still even using any of those medications that you like?
Yeah, absolutely. So you're right. There have been multiple generations of obesity medications that have been out. And this field existed even before we had some of the common names that we hear about today in the news pretty much every day. But we were using medications which were mostly oral at that time, naltrexone, bupropion, Contrave, phentermine, right? And this class of medication or these medications which were out, they had moderate efficacy, but they also had some concerns with their safety profiles and also some of the things that we may have heard about with previous medications, right? There was a bit of a scare with some cardiovascular safety with some older medications as well, which were retrieved off the market. And, as we saw things develop in the diabetes world with some of these medications, we had GLP-1s out since the early 2000s that were being used to treat diabetes. We saw that one component was that, sure, the sugars were getting better in patients with diabetes, but they were also losing weight. And then they started being investigated for using them as treatment options for obesity medicine. And I think the beauty really about these medications is that they really have good efficacy when it comes to weight management, sure, but they also have multiple targets, right? They're not just lowering weight, they're lowering it in a very effective manner. So now we're in double digits, but we're also looking at other targets throughout the body that they're affecting, right? So they might be helping with glycemic control. They may be protecting the heart. They may be protecting your brain against non-fatal stroke, things like that we've discovered, which make them different and unique. So they really act in multiple pathways and really focus on that cardiometabolic picture that you were really talking about. And I think that's why these medications have really been path breaking, right? It's not just about treating weight. Now we're bringing in the whole picture about health and where that kind of begins. And I think many people, when we think about disease states, we've commonly heard, right, about inflammation being a root cause of many chronic disease states. And now we're really looking at medications that may be tackling some of these factors, right? And there's so much to study about these medications, but I think we've just touched the tip of the iceberg when it comes to using medications that are rooted in hormones. So now we're seeing GLP-1, we're seeing GIP, we're going to see the introduction of other hormones being used in conjunction. So I think this is the beginning of a new era.
So I think maybe step one, understanding the mechanism is going to be really important. You mentioned some of those words, right? So GLP, GIP, break it down for the listener, maybe like they're in 10th grade. I won't say 10 years old, it's 10th grade, just because what we talked about earlier. There is a peripheral mechanism in terms of its action, as well as a central role, which is also something that I've been really fascinated about. Where do you think it makes sense to start?
Yeah, so GLP-1 receptor agonists, as we hear about them in the news, the larger, broader name for these are really called incretin therapy. And they're acting on a receptor, actually, that we have throughout the body. And the reason these medications work so well is because they act in multiple ways. So centrally, when you're talking about central mechanisms, we know from studies in rodents, right, what we call preclinical trials, that there are receptors in the brain that control appetite, where these receptors sit and these medications act on. So when we talk about GLP-1s, they actually help reduce appetite and caloric intake in that way. The other way they act is they actually slow down the gut. So you feel full and you feel full faster. And the other thing which they do prominently is that they help regulate your blood sugars by acting on insulin when your blood sugars are higher. So they really help with that insulin sensitization or that insulin release when you have a high amount of blood sugar. So it's acting in multiple mechanisms in order to keep you full, make you feel less hungry, and also regulate your insulin levels. So that's how these medications work as a basic. We also know about a different hormone called GIP, which we see as a dual agonist, a dual receptor agonist, we call it, or a dual incretin therapy, which we see in a medication, tirzepatide. So it acts on GLP-1 and it also acts on GIP. And these in conjunction, again, act to decrease your appetite and caloric intake.
The hunger signaling you spoke about, is that what people refer to as food noise?
So a little bit different. I think hunger, food noise is really a colloquial term that we use. And what I've understood from my patients is that this is kind of like a constant static, constant thought, ruminations about food throughout the day, throughout the night, whenever, right? They just have this constant chatter about food. And what we've seen is that people who are on these GLP-1 receptors or incretin therapies, they seem to have less food noise, less constant chatter about this food. It's a very, very interesting phenomenon because we saw this in clinical practice before there was even really a word. And then this term got coined and people started talking about it.
Yeah. I think, Darsh, maybe you and I had this conversation before. I think anybody who's done any type of physique competition or bodybuilding or something where they've tried to get extremely lean will have an understanding of what this is. They might not be struggling with obesity, but here's the way that I explain it to somebody. If you're, let's just say, towards the end stages of competition, you're trying to get ultra lean, your diet is going to be, it has to be perfect in the sense that you cannot afford, right, condiment calories. You can't afford any types of things, right? And then your caloric floor is so low at this point, and you're just running on fumes because you're trying to get to really high levels. What's happening though at that time for those folks is that when you are eating, of course you're thinking about food, but when you're not eating, you're planning your next meal. So you're thinking about how many calories I have left on reserve and 24 hours a day. And that in itself is so exhausting during the dietary phase. And I think we had Joe Faris come on here with his body talk about that. And that's why he likes to take a longer approach, because just the mental aspect of it is so exhausting. I think Chris Bumstead talked about, recent Mr. Olympia, I think 6 times, talked about, okay, look, at some point, like the exhaustion is just not worth coming back year and year. Again, that's willful, right? These people are trying to do it performance level stuff. I think for the person who has never known anything in their life other than that chatter, to quiet that down sounds like a really powerful thing. And
Yeah,
I guess,
I think so.
Go ahead.
I would definitely say so. I think for my patients, when they're on these medications, the first time where they feel like they're not compulsively eating, or that there isn't this constant thought about food. When's my next meal? What am I going to eat? Do I want strawberries? Do I want blueberries? Do I want raspberries? Do I want a chocolate chip cookie? What do you think I should have as a snack? What should I have for dinner? What should I have tomorrow? Did I eat enough? Do you think I need to eat more? Whatever the questions are that come up, it's the first time where they feel like they have a bit of control. A lot of patients have come back and told me, is this what it really feels like for everybody else? They don't have this constant thought, this constant battle going on. And some patients don't even realize that they're thinking about food this much before, as opposed to after, when it's more of just a background thought. It's not really at the forefront of their thoughts in terms of what's really driving your day. And that which is so drastic for people. And this is, I think, when you really take into effect and you see that, back in the day, we didn't really think about obesity as a disease process, right? This was only until 10 years ago where in the medical community it started getting coined as a disease process. And I think really started treating it that way. And I think for people as well, it was always cosmetically viewed, but also it was all just, eat less and exercise more and everything's going to be fine. And now we're discovering it's a lot more than that, right? It's not the case that if you just eat less and exercise more, that necessarily you'll lose weight. You talked about a lot of important things in the beginning when it came to insulin resistance. Some people have medications they're on that drive their weight up. There's environmental factors, there's stress, there's mental factors, this food noise, right? Which potentially may be driving up weight, or by maybe mechanism of driving thoughts about food, these compulsions to engage in more high density caloric foods. There's so many things that kind of play into what contributes to obesity as a disease.
Yeah, Priya, do we have an idea of where food noise comes from, how it starts? Is it cultural? Like, for example, us being South Asian, I know food waste is a big thing in our culture, right? Growing up, you had to eat everything on your plate. Yeah. And I never had food noise growing up until I really started getting more into working out and things like that. And as to what Alpamash is talking about, planning out the next meal, calorie tracking, doing those things, trying to make it more optimized. Do we have an idea based off your patients where the food noise comes from?
I don't think there's scientific consensus really where this truly comes from. I think we're still figuring that out, right? We don't quite know everything. But I think what I've seen across patients is that it really affects anybody. I don't think I've seen anything where it's very much culturally driven in one particular arena versus area. But I think it's something which I've seen that I think culture also does have an impact. Or maybe the environment you grew up in, right? We can maybe approach it even in a broader avenue, right? Where, for example, it may not even be just South Asians, maybe just any household where the rule is you have to finish everything on your plate, right? And I see that all the time in practice. For some people, it's actually that their parent was living with an eating disorder and maybe they were restricting and they saw that as a coping mechanism and then, they fell into that. Or maybe they're living with different stressors that have led them to have an eating disorder, or they're emotionally eating. And there's a lot of different things that affect us from our environment, right? That can play into some eating behaviors. And that's another thing, right? So it's not just when we're talking about these medications, I think on a day-to-day basis, when I'm seeing people coming in for treating obesity as a disease, right? Or treating overweight or any metabolic condition, we're always talking about not only their lifestyle, but also behaviors, right? Eating slow, chewing your food, paying attention to your food, right? These are all really important.
So let's get into patient selection. I think most people in the know, and I think those who are rigorous about this process, when anything good comes along, there's certainly going to be abuse. And I'd love to kind of understand with an open mind from your perspective in terms of who is eligible for these medications. I want to acknowledge this because I don't think I told you this. I've said this on record here is in my time of practicing medicine, granted, I haven't been practicing that long, but maybe I'll say in my time of being invested in health, I would say this is probably the most revolutionary class of drugs. And maybe it's recency bias, maybe not. For and you tell me if you agree. But at the same time, I have a lot of concerns from the legislative process in terms of everybody who has access to it, who shouldn't. So I'd love to understand from you who you think is appropriate. Maybe we can match specific drugs to patient phenotypes and so on and so forth.
I think it's not so much about right or wrong. It should be individualized to what your goal is, right? And what maybe also your other medical conditions are, what your goals are. And that's really, truly what's going to determine if this drug is a good fit for you, right? Or if you're a good fit for this medication profile. Both have to kind of match, right? And right now, if we get into technicalities about what the indications are for these medications, those have also evolved, right? So before we used to see, for example, BMI cutoffs on the medication labeling. That's changed. Now they're expanding that to say it's for these incretin therapies, patients who are living with overweight and a weight-related comorbidity or obesity, right? So for semaglutide 2.4, for example, or tirzepatide, which are both indicated for weight management, that's what you'll see on the labeling. And that's because we're moving beyond weight as a number, right? We're trying to also expand it to different arenas of measuring how we look at obesity and overweight as a diagnosis, right? And you're going to see there's a lot of community guidelines that have also updated, but also a lot of different measurements that we use in the clinic to determine that. For example, we're looking at waist circumference, or we're looking at waist to height ratios. We're looking at different things, body compositions, right? It's not just the BMI number anymore, right? That we're looking at. So that's one thing. So on the labeling of some of these medications, you'll see living with overweight and a weight-related comorbidity or obesity. The second thing is they've also expanded beyond just treating weight, as we're talking about, with these medications. So for example, for semaglutide 2.4, recently, there was an indication that came out for MASH, right? Formerly known as fatty liver disease, or NASH, now known as MASH, right? And it's really indicated for fibrosis stage 2 or 3 of MASH. So that's what it's indicated for. And there's also an indication that we have for reducing major adverse cardiovascular events for individuals with this medication. And then for tirzepatide, there's also an indication for moderate to severe sleep apnea in individuals living with obesity. So we've really seen a huge expansion when it comes to what these medications are being used for and what their indications are. As opposed to, I would say, those are your indications now, as opposed to that, they're also contraindications, right? And some of those absolute contraindications are really if you have a personal or family history of medullary thyroid cancer or MEN2 syndrome, right? And most people have never heard of these specific things. When I ask patients, do you have family history or a personal history of medullary thyroid cancer? They're like, what's that, right? And that's because it's usually a rare form of thyroid cancer. And MEN2 syndrome is pretty much the same. People are like, what is MEN? Which men are you talking about? And I have to explain to them, no, not men. We're talking about MEN2 syndrome, and medullary thyroid cancer is a part of this syndrome that, can exist in families. So that's two of the contraindications that you can have. The other contraindication is if you've had a serious hypersensitivity reaction, like angioedema or anaphylaxis to the active ingredient of the drug or any excipients, meaning whatever else is in the drug. So those are contraindications. I think the other group that you want to think about is if someone is pregnant, they should not be on these medications. Okay. And also if they're trying to conceive, for 2 months prior to that, they should not be on these medications because we don't have data. So we usually give a 2-month window prior to people trying to conceive.
I remember reading something on Medscape that some observational data of pregnant women, retrospective analysis or something like that. Is there anything, or are there any trials that you're aware that being looked at that specific population?
It's very interesting. There are such few medications that we use in pregnancy. And I think a lot of that is due to the fact that we are not able to complete some of those studies, right? Because we don't know what the effect will be on the fetus potentially. And so it's very hard to enroll people into those studies also. But I think one thing I can say is there is a registry. So if you have a patient who is on one of these medications and happens to be pregnant, the industry is collecting that data, right? And you do report that to the pharmaceutical companies. And they do have a registry of that. So I'm not in tune with if there's anything active going on right now in terms of studies in patients who may be pregnant and using these medications, but there is a registry to, I think, surveil that.
That makes sense. So let's get the terminology right then, because I had mentioned obesity and actually you said that the BMI is no longer cut off. I think we can all agree, we talked about before how BMI maybe at the population level makes sense, but maybe not even so as much anymore. At the individual level, it's completely useless. How would you, if you were teaching me, like I'm a medical student, how would you teach me to pick up overweight versus obesity so I can make the diagnosis appropriately? And then we can talk about the medical comorbidities that might change the game in terms of who the medication is right for and who's right for the medication.
So I wouldn't say that BMI is completely out of the picture. I think what I was talking about is more of the product labeling. But what I will say is that it's actually quite complicated. So, for individuals, when we're looking at even BMI cutoffs, you're right. It's a population tool, but it's an imperfect population tool. So it doesn't account for where your fat tissue may be sitting, right? And we know that it's very important if it's actually sitting in the visceral area, in the abdominal area, that is a independent risk factor for heart health, for cardiac disease. And so we can't tell that from BMI. The other thing we can tell is the distinguishment between, the different types of tissue, fat tissue, muscle tissue, right? So I always tell my patients who come in, if I put Mike Tyson on the scale, for example, or an athlete, right, they may come out, but their BMI being much higher, but that doesn't mean that they're necessarily overweight or obese. It may just be that they have a lot of muscle and muscle is heavy. So oftentimes we send people for body compositions, which will give you the percentage, depending on the machine, of what is their scale for overweight and obesity. Okay, the other thing that is there is even within BMI, for certain populations, there are different BMI cutoffs for overweight and obesity, which I think a lot of people don't know, right? So even for the South Asian population, for example, BMI of 23 is actually considered overweight. And a BMI of 25
Yay.
considered obesity, right? That's another thing. A lot of us in certain populations hold weight in a different distribution, right? For those populations, it may be that abdominal, that visceral fat tends to accumulate earlier, but also some populations also have less lean muscle mass, right? So South Asians is another population like that. And then there's also waist circumference, right? And that also differs for males and females. So everything is very individualized. And I think that's what it's going to really come down to, right? So for example, if I have a patient coming in who may be of South Asian descent, and they're telling me about their journey and their BMI is 24. This happens very commonly where they're coming in from another physician who said, you're not overweight. You're not at a BMI of 27. So you shouldn't be treated. But actually for their ethnicity, race, right, gender, all of these things matter. They are actually qualifying for overweight. So it is very nuanced. It's very interesting, actually. I really encourage people to actually look at even other countries and what their cutoffs are for obesity. Very, very different across the world internationally.
Yeah, Adil Khan actually at least taught me about this, right? I think it's, if I'm getting it right, it's the adipose tissue overflow hypothesis that you're talking about. Like the South Asians tend to, have a lot more visceral, whereas Caucasians will have more subcutaneous fat, and that's more inert. Not too worried about that. Here's what I'm thinking about. If you do have that South Asian who is 24 and is overweight, let's say they have hypercholesterolemia, right? They got to get on this. They don't got to get on this, but they would be potentially a good candidate if all other things lined up. What's the insurance company saying? Are they still using the 27, or are they understanding the nuance that you just described to us?
Yeah, so that's a challenge, right? So we are very behind in the world of obesity medicine. So that's why we still use BMI a lot, because the truth is, even though, for example, AMA had mentioned that we should use other metrics, right? Whether that's waist circumference, ratios, body compositions, in conjunction with BMI, a lot of our guidelines, medication indications were all structured around BMI. So that's why it was very important. Many of us as physicians were not even documenting BMI originally. So one, there was a push, hey, let's document BMI, right? In order to even list this as a chronic disease, it was important to do that. But two, then when we look at our infrastructure in medicine, it's all based off BMI. And so your indication for medications originally was coming off of BMI. Indications for surgery was coming off of BMI. And so we're still seeing that we have to make a push towards a change. So it's actually very important that physicians, yes, to log BMI, but then to also use other metrics to demonstrate, for example, if you send a patient for a body composition, right, and their BMI maybe is 26, but you send them for a body composition and the fat tissue percentage is higher, indicating obesity, it's important to show that contradiction right? To insurance companies to say, hey, even though the BMI is 26, we got a body composition for this patient and the body fat percentage is 36%, which is something, right?
Yeah.
And we want to treat this individual with medication therapy. Because just by looking at somebody, we can't tell what the body fat percentage is, and neither does BMI distinguish that. And we are seeing a different phenomenon also, which colloquially was known as skinny fat. That was another thing which was happening, where people look thin but don't have as much lean muscle mass as they do fat tissue, and the fat tissue percentage was. And that's why thin does not equate to healthy, right? And so we're still fighting a lot of these basic constructs that we have, thought constructs that we have in the medical community and even in the general community, right? We tend to stigmatize a lot, when it comes to weight, appearance, right? These types of things. It's just like how you can't, maybe, it's hard to tell looking at somebody what other disease processes they may have. So it's just like that, right? So we're still pushing for that. I would say most insurances are still going by BMI, and sometimes it's even hard because they may have plan exclusion because it's not that every employer is opting into AOM therapy, right? And so that's been really difficult. So it's not as simple as, we just place the order and we're good to go, right? There's a whole team that goes behind this who does prior authorizations for insurance. It's a hiccup because it takes a lot of time, effort, manpower. We get rejections, we do appeals, we do peer-to-peers, lots of phone calls, and it can be frustrating for people. Because imagine if you come in as a person seeking help to your doctor, and maybe this is the 7th time you've tried to lose weight in your lifetime. And now you have a stall, and you're getting frustrated, and you're getting disappointed, and you're like, you know what, forget it. I don't want to deal with this. So I'm just not going to deal with it. And that's understandable, because you can imagine if, for example, if we applied to professional school 7 times and failed, would we even apply the 8th time? A lot of us wouldn't, right?
Probably
Because
not. I wouldn't.
right? Like, how many times are you going to face rejection? So a lot of people are on, really the edge of their seat, really coming in with a lot of hope for help. And if they're facing a lot of these barriers, it gets increasingly frustrating, increasingly difficult, increasingly disappointing. Right. And we try to do our best with this, but sometimes we do get pushback from insurance. Sometimes, there are different caveats. Sometimes it's patient populations that really need it. Medicare, Medicaid. There have been some advances with Medicare, but there's a long way to go, right? There's a long, long way to go. We went through a whole battle of shortages, right? When these medications initially came out, there was an uproar for demand, and I think the manufacturing just wasn't fast enough. It was an injectable. Now we have orals, which have come out, right? So we'll talk about that too. But a lot of things have changed in the landscape, even though these medications are relatively new, quote unquote. Even though older versions have been around of these injectables since early 2000, when they really came into the obesity medicine space is really when I think they gained a lot of popularity. I mean, how many medications are we here being talked about at the Emmys, the Grammys, award ceremonies, right? And the news every day.
Yeah. You were talking about employers and insurance companies not opting in. In fact, I heard quite the opposite. A lot of them were opting out that initially were opted in, and patients were covered. And all of a sudden they're getting letters, and effective January 1st, 2026, you are no longer going to, or this medication is no longer going to be covered. And they're like, hey man, I've been on this medication for X amount of time. In fact, Optum, which is the drug cover provider for my employer, is actually just sent a PSA out to everybody. It's, the price, we're still going to cover, but the price is going to triple or something like that. And it just doesn't make sense. But I guess a lot of things don't make sense when you're practicing medicine. And we've done many of those episodes here. I am interested to hear about your experience with peer-to-peer. Walk me through what that conversation looks like and how successful are you? I mean, the evidence you're presenting here and the nuance you're adding is compelling for me. Again, I acknowledge my bias. I also know what their objectives on the other side. So how successful are you? What's your success rate on that? And what does that conversation look like when you're trying to get approved and they're saying, no, they're not a candidate, quote unquote?
Yeah, it's tough because one thing is sometimes you have to really sit there and explain the entire case to the other person on the phone, right? And you need to explain why it's important. And there's multiple scenarios where you can be the patient came in from a different insurance plan, switched jobs, they were on the medication, whatever it may be. But you really have to go through the entire history and sometimes even pull in papers, right? And indications that may be supporting that, right? And why? Maybe it's just not the weight. Maybe they're a patient who had a cabbage, right? And you're using it for MACE reduction. It's really about building the case about why they need to be on this medication therapy, but also why they need to stay on it. So these are long-term medication therapies. And I think oftentimes we're still seeing sometimes problems with insurances where besides losing coverage or coverage changes or employers changing plans going into different years, sometimes we see like, oh, the patient reached normal weight, and so they don't need this medication anymore. No, it's like saying that if we treated someone's blood pressure and it was normal, I mean, we should stop the medication. It's normal because we're on the medication. So it's the same with this, right? We're able to manage not only the weight, but maybe reverse.
Yeah. Priya, I want to jump in there. So that is the most logical thing for somebody like me, but I don't know. We don't have evidence. You're not pulling in papers for that. So when you say that, like, what are they saying on the other side?
Well, actually, we do have.
Do we? Tell me.
Some of these medications.
Oh, you're talking about the regain data? The regaining weight? Okay.
We do have some of that data. So there were studies on both semaglutide 2.4 and tirzepatide that showed what happened when people were on the medication for a certain amount of time, then the medication was stopped. They were either randomized into groups to continue the medication or to be off the medication therapy. And we saw that they had significant amount of weight regain. Now, they didn't regain all the weight. You have to remember in like these studies that we're talking about, this was in conjunction with lifestyle changes, 150 minutes of exercise, 500 kcal deficit. And so you have to account for that as well, but they did regain a significant amount of weight. And that's when you start to tell, the person you're on the phone with, hey, we were able to reverse their prediabetes. I was able to put their moderate to severe sleep apnea into remission. I was able to control their cholesterol levels through this medication therapy. And if we take them off, these things may come back because the medication is not acting in your system, right? And it's very hard to maintain a steady state. We also have things called metabolic adaptation, right? And a lot of these medical conditions are actually, they have a component of being weight related as well. So if your weight regain starts to happen, the medical conditions that you just improved or put into remission or reversed may also tend to get worse. So we try to explain these things. Am I always successful with this? No. Am I sometimes? Sometimes, but not always. I wish it was better, but we have to do our part because the more we advocate for our patients, the better it will be. I think that's also easier said than done because not everyone has the resources that I'm very grateful to have. In my office, we do have a prior authorization team, right? So they're able to submit the prior auth. They're able to write the appeal. And I can get on the phone for the peer-to-peer, right? But if it's someone who's in an office by themselves, right? A lot of work. That's a time. So it's a huge burden, I think, on providers that are trying to do the right thing. And sometimes you'll even see, this one always gives me a chuckle, that actually the BMI cutoffs are different for certain insurances. So they will say, actually, the person you're requesting this medication for doesn't have a BMI of, let's say, 35. And I'm like, wait, hold on. The indication is actually overweight and weight-related comorbidity or obesity.
We're just changing the rules for everybody now.
Wow. So sometimes, we do see these things. It's very interesting, some of the things that we're seeing, or they have to try and fail a certain medication therapy before they get on this, right? And so we do see things, and it's been ever changing. Just like the medications have been changing, the rules have also been changing with a lot of these things. And we've tried to adapt as best as possible.
Priya, I think it's important for our audience to understand who you're talking to when it comes to peer-to-peers. Do you mind kind of just explaining, who is on the other side? What is their knowledge level of this? Because I think that's just a huge transparency issue too, that a lot of patients don't understand.
It can even be a pharmacist on the other side working for the insurance company. It can be a physician on the other side working for the insurance company. So it really just depends.
And then you use the words or abbreviations, I should say, cabbage and MACE. Can you just explain what those are?
Yeah, sure. So when I was referring to cabbage, I was talking about a cardiac procedure, right? And then like a coronary artery bypass graft. But for MACE, I'm referring to major adverse cardiovascular events, right? So these medications actually showed reduction in MACE outcomes, MACE, which stands for major adverse cardiovascular events, but they're really referring to reduction in risk of non-fatal MI, stroke, or cardiovascular related death.
Yeah. Yeah. So on the topic of BMI and having a case to present why your patient should be on these medications, what other testing are you doing? You mentioned body composition, maybe through DEXA or something, but are there any other panels, lab testing? What else is that kind of pre-checklist that you use when it comes to seeing whether it's a good fit?
Yeah. So obviously we get our basics, right? We get our kidney function, liver function, check for a thyroid level, TSH, free T4, cholesterol, an A1C, a fasting blood sugar. I also like to check for a fasting insulin level and calculate a HOMA-IR. There's a lot of, difference about how people approach that. Some people go by more of the standard that insulin resistance is a clinical diagnosis, right? There's no official testing for insulin resistance, but as a tool I learned in fellowship was using a fasting insulin level and a fasting sugar level to calculate a HOMA-IR to get a better sense. So that's something that I still do in my practice. There's also other tests that you can get depending on the person who's sitting in front of you. For example, if they have high cholesterol and they have family history and they've never gotten checked, maybe getting an LP(a), but these are not specific to the medication itself. This is just an intake that I do because what I've realized is you want to screen for everything metabolic, right? When someone's coming in for obesity or overweight or for weight management, you want to screen for other weight-related comorbidities or any weight-related complications or any other metabolic disease state, right? That may be appropriate. So for example, in our office, we actually have in our weight management center a FibroScan to screen patients for, as I mentioned, fatty liver disease, MASH, which it's now known as, in patients who may be at higher risk, for example, in the type 2 diabetes population or in the obesity population. So we actually calculate something called a FIB4 as well, which risk stratifies patients for MASH as well. So it's it can get very complicated. That's, we could probably have a whole session just talking about MASH and FibroScans and FIB4s and a lot of complicated terminology. But I think the point that I'm trying to get across is before we were kind of doing things where we were treating weight last. Now we're using weight management at the forefront of things, and we are really having bi-directional screening, right? So if someone's coming in with diabetes, I'm also checking, hey, can they benefit from some weight management? If someone's coming in for weight management, I'm making sure that they don't have pre-diabetes or diabetes or dysglycemia. And so it's really a bi-directional relationship.
Gotcha. Any psychology testing?
Yeah. So, one thing is I actually have a 4-page intake sheet for my patients. So it's quite extensive, quite long. And actually in there, we talk about eating behavior. So emotional eating, stress eating, all of that stuff. And I always ask about a history of an eating disorder or disordered eating, and also mood disorders, right? So like anxiety, depression, very common, prevalent in these populations. But also for these medications, you also want to ask if anybody has a history of suicidal ideation or active suicidal ideation or a history of suicide attempt. That's also important to ask. In these medication therapies, they usually said avoid that if that's the case. But these are really important things to ask about because I think, honestly, if there was a perfect construct, there should always be a psychiatry component too. So if there was a psychiatrist in our office or a psychologist, a nutritionist, an exercise physiologist, and an endocrinologist, it would be great. It would be ideal. It would be perfect. But that's not always the case, right? It can be deconstructed medicine at times. And we do our best to do that. I do work with a clinical psychologist and obviously the psychiatry team as I need to. But, we've built our bridges and have counterparts in mostly every field, right? So at NYU, I worked on kind of building the obesity clinical care pathway. And now we're actually working on building the cardiometabolic pathway. So there's a huge infrastructure that comes with creating pathways for patients that are coming in for metabolic care.
So let's say you've gotten somebody who identified they're going to be a good fit. You're starting the medication, you've gotten all the baseline, and you've had those conversations about actually maybe as you're starting the medication, what are some of the, I guess, informed consent, so to speak, where you'll explain to them, hey, here's the expectations. This is going to be our process. Walk us through that conversation and what that looks like when you're setting expectations for this medication.
Yeah. One thing is there that I always tell my patients that lifestyle changes are always going to be a part of it. It's definitely going to entail nutrition. And it's also going to entail exercise, right? And beyond that, there's medication therapy and then there's surgical therapy. And then we talk about what combinations we want to use and what are going to be a good fit, right? And along with, let's say they choose lifestyle and medication therapy, then we're going to talk about each one very specifically. And I really walk in with a exercise prescription for patients, or really I would say not even exercise prescription, a lifestyle prescription, right? So we're talking about everything. We're talking about how much they're sleeping, how their sleep quality is, how much water they're drinking, how many steps they're walking, what their stress levels are like, how much strength and resistance training they're doing, if any, right? How much exercise, maybe cardio they're getting in. And we kind of tailor that. As far as these medications go and nutrition, it's extremely important because I think there's a huge misconception that while you're on these medications, it's okay to not eat. That's not the case, right? The goal of these medications is not to not eat. It's actually to help you eat better, right? And actually to maintain your nutrition and your micronutrition. These are all really important things. So I always tell people that we're going to use this medication as a tool, as it is, right? It's not the whole treatment plan. It's a part of your treatment plan. So alongside nutrition and exercise, we're going to use the medication. And for the medication, one thing you really want to understand, because it's slowing down the gut and making you feel full, it's important to have smaller, more frequent meals. The other thing is you want to keep hydrated when you're on this medication. And you also want to watch out for side effects. So nausea, vomiting, constipation, diarrhea, GI side effects are one of the more common ones that we see with these medications. And you want to make sure you avoid certain triggers. So example, fatty food, fried food, greasy food. These things can all cause maybe people to feel nauseous, potentially vomit, have diarrhea on this medication. At the same time, it's really important to pay attention to things like fiber when you're on this medication to avoid things like constipation, to make sure you're drinking enough water to avoid things like constipation, to make sure you're having good movement to avoid things like constipation. So these are sort of the constructs that we kind of start with. I also always tell my patients that we're going to have really frequent appointments to see how they're doing. And if they are having severe nausea, vomiting, diarrhea, any side effect, they should let the office know, right? I think that's really, really important because I think these medications sometimes are perceived as being just a prescription, right? And it's fine. These meds are easy. You just take them and everything's good. But it's a lot more than that, right? It's not as simple as just writing a prescription. There's a lot of counseling that comes with these medications because the truth is they are medications. And I think sometimes we forget that in all the buzz and popularity that these medications have had. I think sometimes we forget that they do require monitoring, follow-up, counseling, right? And so we really need to do our due diligence with that.
I'm thinking about, I have one patient who I've been taking care of for about 3.5 years now. And she had a gastric sleeve about 3 years ago. And I kid you not, I see her about every 2 to 3 months for some musculoskeletal issue. And almost every time in that interval, she has been admitted to the hospital because of a complication that she had from that bariatric surgery. And every time I see her, I just said, man, I just wish she had waited 6 months or 10 months or whatever. And she could have been on one of these medications. So now that's my bias, but I want to know from you, who's the patient that you're still recommending surgery?
So, there are also, first of all, I'll say, some patients, surgery is definitely a part of their treatment. Does surgery have certain risk complications that come with it? Yes. You're right. Back in the day, we didn't have many options. Now we have more efficacious options. Our medications can lead up to 15 to 20% weight loss, but there are patients who may need more than that. And when we're talking about these percentage numbers, these are maybe average, right? For some patients, they may not lose that much weight and some patients may lose more weight. So one thing we don't talk about is that some patients actually have what we call failure of therapy on these medications. They may not lose any weight or they may lose less weight than anticipated.
Yeah, we don't hear about that.
Yeah. So that happens. I see that a lot, right? I see that, I won't say a lot, but I see it more commonly than I think people would think, right? So generally it's about the way we look at it is a lot of times for insurance, right? People want to see about an improvement of at least 5% in 3 months. That was what we used to think about for as therapy working and what insurance was asking for. So sometimes for people who don't achieve that, that's considered failure of therapy, right? So we do see that in the office as well, but that is less than 10% of patients, but it still does exist, right? And so for those patients, bariatric surgery may be an option, but for patients who may be requiring more than 20 some percent weight loss, you may have to think a bit further. Now, we do have medications coming out that are going to be equivalent to bariatric surgery, right? Percentages, 25, 30% weight loss. But even beyond that, you need to look at other things, right? There's a score, an Edmonton score. There's also other scoring systems, I'm sure, but there are scoring systems that actually look at in totality how maybe someone's weight may be affecting them in other arenas of their life, whether it's emotional, mental, physical. Some people are not able to proceed in their daily life and maybe facing immobility. Maybe they're wheelchair bound, right? Maybe they're using a cane. Maybe they are internally stigmatizing. Maybe they don't want to seek healthcare because of how much they've been stigmatized against, right? Maybe they, I hear about these things every day. I see these things every day, right? So I think we really have to take that into account. If you have a patient who may be immobilized by living with obesity, maybe suffering from conditions like heart failure or other things, maybe having anxiety, depression, maybe have faced a lot of stigma in the community. These may be patients where you may need to use all three. Maybe you need to do lifestyle changes, medication therapy, and bariatric surgery. I think there's a continuum of therapy, and it really just depends on the patient who's walking in. So I work very closely with the bariatric surgery department, actually, and what we'll often see is patients may be utilizing GLP-1 therapies before surgery, and sometimes we even utilize them after surgery to maintain weight. So I think there definitely is a place for surgery. Sometimes that may be different for each institution. Maybe we also have classes of obesity that maybe listed, maybe that's class 3 obesity above. But it just really depends on the patient who's coming in. Maybe the patient says, I don't want surgery, and that's totally fine. So it really depends on what they're looking for. Sometimes we have patients who come in and say, I want to try lifestyle changes. I don't want medication or surgery. Then we wait, we see, we watch how the progress is going. And if it's not going, I say, listen, I think we need to revisit our plan and see what we need to do. And maybe then at that point, they're amenable to medication therapy. And maybe they make good progress. And maybe they need surgery on top of that. And that's still a possibility.
Yeah. Earlier, you mentioned frequent visits. What's the interval that you'll see them for?
Yeah. I mean, before in the beginning, we really tried to see, I think ideally you would want to try to see someone every month. I think a lot of offices are inundated with patients, and I think that's stretched out a bit to possibly closer to 6 to 8 weeks for people. So in my office, I try to aim for about 1 to 2 months. And then once they're more so on maintenance, maybe every 3 months, they're in the office for a check-in, but at least every 1 to 2 months. They're there. I know a lot of institutions that are actually trying to create more bridges to involve more people in the clinical care pathway, even utilizing pharmacists or NPs, in between physician visits to make sure that patients are getting appropriate follow-up. So like our pharmacy will actually call patients and check in on how they're doing as well.
Is that only if they're filling through that pharmacy, I'm guessing?
Yeah.
Yeah.
That's only if they're filling through that pharmacy.
Yeah, that's awesome.
Yeah, I actually feel like it's really nice because the patients feel like also that it's very helpful that somebody's calling in between and asking, hey, are you experiencing any symptoms? We can reach out to your doctor's office if that's the case, when they're checking in and kind of helping them along.
It's interesting because that's almost the standard when you're doing a specialty medication from any specialty pharmacy, like Credo or I don't know, any other ones that you think about. They will do that. They'll check in. They say, would you like a consult with the pharmacist and do that kind of stuff? I guess, yeah, this technically should be that, but that'll also make it much harder for people to acquire it, probably, if that was the case, right?
Actually, we have a specialty pharmacy, so that's a specialty pharmacy, so it is through that. But it's not so much harder to acquire. I think I was also lucky because at the time that it was introduced to our office, I was incorporated into the system very early, and I know them very closely. I work with them very closely. I built that relationship with them. So it's pretty smooth for my patients to go through the specialty pharmacy. But again, not every person who may be prescribing these medications may have access to a specialty pharmacy. So I feel every institution, every office, every clinic has a different way of operating when it comes to this.
Cool. So let's talk options. You've mentioned semaglutide, tirzepatide, right? Those are the two main players, and there are probably there are other two. But let's talk routes of administration, interval. There are different ways people can get that right now. Both Eli Lilly and Novo have a direct M for those. Can you talk about all that stuff?
Yeah. So semaglutide 2.4, right, you have from Novo Nordisk. So starting doses are 0.25 milligrams every week. It's an injectable therapy. You go up. There are other doses, right? 0.5, 1 milligram, 1.7, 2.4 is the maximum. What I would say is we don't necessarily potentially need to go up every 4 weeks, right? It's usually based on the patient's tolerability, how they're doing, how much weight they're losing. These are things that are really important to look at. How the side effects are, if they're tolerable for the patient, how much weight they're losing is also another component. But also, you want to see that they're engaging in all of their lifestyle changes, how they're feeling with things. And some people are more sensitive to the medication than others. Some people may require a little bit more medication. So it's really individualized. So that's why I think those follow-up visits are really important to see how everyone's doing. It's recommended that you can potentially go up every 4 weeks, but it's not necessary. But tirzepatide, also, there's a wide range of doses. It's starting at 2.5 milligrams, and it goes all the way up to 15. And there are doses in between. There are maintenance doses also for these medications, depending on the indication, right? So for tirzepatide, it's also depending on the indication what the maintenance doses are. And now we also have oral Wegovy, which is brand new, right? That has just come out this month. In fact, at the beginning of the month in January. And it's only been out for a few weeks, but it's been interesting to see. They have doses starting at 1.5 milligrams daily, and it goes up to 25 milligrams daily. And it's a little bit different because the other ones are injectable therapies that are used weekly. This one is a oral medication that's daily, and you have to take it with a small amount of water and wait for 30 minutes before you either drink or take any other meds. So it really depends on your absorption of the drug. And so there is a little bit of a caveat there where maybe people were administering this medication once a week, didn't really have to take it with food, without food. It didn't matter. Time of day, everything. But here you need to be a little bit cognizant about that pre-administration instruction.
Yeah. Is it just 30 minutes with any other medications or even anything, eating even just breakfast or meal?
Even eating. And there's medications which you may need to watch out for a little bit more, right? Like, for example, levothyroxine or something like that.
What is it? Like, what about like coffee and stuff? Does that interact with any?
Yeah. So you want to wait.
Even that. Okay.
Yeah.
Wow. Okay. Darsh, anything?
I think the main things that I think about, so like in the inpatient rehab, I have a lot of these patients now coming on these medications, but their last dose might have been a month ago. How do you think about either restarting it or, that's a lot of the questions that we get is, can I go back to that same dose? Do I have to restart? Should I just wait to the outpatient setting?
Yeah. So, it's very common for patients going to endoscopies, colonoscopies, any procedure under general anesthesia, deep sedation, that they should talk to the operating provider about when they want to stop the medication. And sometimes you may be hospitalized and may hold the medication, right? When you're restarting the medication, it's really important to talk to your doctor about when to restart, right? So if you have a operating provider that's telling you, hey, stop a week before, it's really important to talk to your prescribing doctor about how to restart that. So generally, I would say if it's been beyond 2 weeks since your last dose, you should probably, the manufacturers say you have to go down to the beginning dose again and slowly go back up. I think it's really important to formulate a plan with your doctor. If it's truly been like a month post your last injection, it's really important to talk to your doctor about getting back on schedule from maybe going down back to the lowest dose and then slowly going back up.
And what's the current thought on weaning off the medication versus maintenance? Does that just depend on patient, or given the data now that we know there's, you can definitely get that wean back? How do you think about that?
Yeah. So these medications are definitely for now indicated for the long term, right? We're treating obesity as a chronic disease state. So we're using a chronic regimen for that, right? So they're really indicated for the long term. So the goal is to actually not only lose weight, but to maintain it. And that's usually through sustained use of the medication. Now, a lot of times we've had trouble over the past few years, right? Where we've had medication shortages, we've had to jump from one medication to the other, or maybe use an older school oral agent, right? If patient wasn't able to find the medication or if insurance coverage got dropped. And so sometimes we have to get a little bit creative with some of these things, or we've had some patients who maybe have lost coverage or can't afford to continue on the GLP-1 out of pocket. So these things have definitely happened in real life, where maybe someone is abruptly stopped and we have to get a little bit creative and see how we can help maintain the weight. So that's definitely there. But as far as a protocol to come off the medication, there's no official protocol on how to come off the medication. So that is not there, right?
Priya, if you had a patient, let's just say they're on tirzepatide and they're on They've slowly been weaning down. They've achieved their targets. They're happy with where they are. Life is better in a variety of contexts. And they're currently, you got them down to 5 milligram. The next logical step is to go to 2.5 milligrams weekly. But there are some people who are advocates, and I'm one of those, who would say, actually, I would rather stay on the 5 milligrams and extend the interval. Now, I understand the pharmacokinetics of it, half-life, everything that the company will argue. How would you approach that case?
So this is off-label, right?
Mm-hmm.
On-label, they will tell you that that's a maintenance dose. Now, there's a couple of tricky things. Maybe you say, go down to 2.5. Maybe the insurance won't let you. Maybe they'll say that's not a maintenance dose. Some insurances may let you. So it really depends. The other thing is when we're talking about half-life, right? So it really depends on the drug. So let's say for tirzepatide, it's 5 days. So I feel like once you start going beyond 10 days, that's a lot. Half-life is already dropped twice, right? And so I think that's a little bit trickier, right? If you're going beyond that, you also need to make sure when you're re-administering the medication, if the patient's having too harsh of side effects, right? So that's something when we're talking about in practice, what that looks like. But I don't think there's a perfect formula. I think it's something that we definitely have to be careful about. There are other drugs that are on the horizon that are being studied for even once a month administration. But again, with some of those studies, we did see harsher side effect profiles for that. So I would say no perfect formula right now, but something to be definitely careful about since it is off-label. And see
I think the next thing that we talk about will make a little bit more sense and why I approach it this way. So I'm extrapolating some of my thought process. Let me just explain to you. You tell me where my gaps are, okay? So the caloric cycling and refeed or caloric shifting model, again, comes from physique competition again, I keep using those because that's where most people in aggressive weight loss studied. And this matters because, one of my biggest clinical concern and a lot of people's clinical concern is muscle loss is a big thing. Well, one of the things that we've learned and we've known for a long time is that when you have this caloric and macronutrient cycling, you can preserve your metabolic rate a little bit higher. And so by extending the interval, you are going to have low days. So let's just say you're going Q10 days, every 10 days. Sure, for the first 24, 48, 72 hours, your consumption will be a lot lower. And then day 8, 9, 10, it'll be a lot higher. Mm-hmm. That is that shifting model. Now, the evidence is sparse on that, right? A lot of studies will show actually continuous energy restriction where you keep your calories in a deficit every single day achieves the same amount of weight loss. But I think that there is enough evidence that this is what isn't applied in practice when you look at people who are getting in that aggressive fat loss phases. And so that's kind of where and now granted, I've only had 2 patients and I'm probably a fraction of what you're doing. So I wanted to get a sense of, and I've also heard Dr. Nadolsky talk about this, I think on social media. And this is all he does, is my understanding at least, where he has a virtual telemedicine clinic. And I was like, okay, well, that made me feel a little bit more validated. But does that make sense, or am I missing something there?
Shout out to Nadolsky. He's a good friend. But I would say these things are very interesting in the sense that sometimes we can think about theories and everything, but then you also have to think about the person who's sitting in front of you, right? So sometimes let's say I put a patient and we decide we're going to do every 10 days. And then they come back and they're like, Dr. J, I'm really hungry those last 3 days. And it's, the food noise is coming back. I'm making worse choices. I don't know if that's the best option for me.
Sure.
Right. And they might come back and say that. And so you might have to change your plan again. But in terms of, the cycling that you're talking about, one thing I will say is, I don't know how much really, besides the hunger cues, how much that, if there's a drastic shift in weight in those 3 days, let's say, or any cycling between that. But I'm not really sure. You guys are more in tune with that kind of cycling that happens with diet and all the things that you're talking about. But I'm not really sure if we have any data on what would happen with that cycling on every 10 days. I think
we don't with GLPs. That's for sure. We don't have that yet. Yeah.
So something to be looked at.
Yeah.
But they're looking into a lot of things like fasting also. Mm-hmm. And also looking into maybe, even for surgical procedures or for endoscopies, colonoscopies, a lot of places have adopted going onto a liquid diet, for example, for easing symptoms and stuff like that. So I'm not sure where we'll be in some time with some of this stuff and intervals between medication dosing. But I think it's an interesting realm right now. Like I said, there are medications that are being studied for even once a month administration. It's just we also have to be careful on how the experience is for the patient, if it's actually tolerable and if they're actually getting good results. So it's not just about the quantity of weight loss, it'll also be about the quality of that weight loss.
The other thing I think is worth
Right.
mentioning here is the tolerance to the side effects, right? So for instance, you could have a little bit of reflux, nausea, things that you mentioned earlier, but the longer that you're on the medication, your body acclimates and you will have less of a response. Is that true?
So there's something called metabolic adaptation, right? I don't think it's so much, there's two really phenomena I think that go on. One is a lot of times I've heard from patients, doctor, it's not quite like the first time when I took it. And that's because your receptors are naive at that time. They haven't seen this medication, right? And now all of a sudden, let's say you're going up from 2.5 to 5 milligrams, right, of tirzepatide. Maybe it's possible that your body has already seen this medication therapy, and so it's not as prominent that effect you may be seeing. For some patients, you may hear that it's not quite like that first time when I took the injection. It doesn't quite feel that way. The other thing you have to realize is that, you also sometimes hear from patients that I don't quite feel the difference, but I can promise you, if they're not on the medication, they will feel that difference in the hunger and the difference that the medication has made. But there's also a phenomenon called metabolic adaptation, right? Where your body may sense that you're doing really well. The weight bracket is shifting a certain way. And your body may also try to fight back and release more hunger hormones to try to combat that satiety. And it may give you a push towards really making people more hungry and trying to bring the weight back to a certain set point. So that we also see.
Makes sense.
So whenever we have any difficulties, I think, with things like metabolic adaptation, things like that, it's always really important to go back to protein intake, fiber intake, water intake, strength training, all of these things that we can use to combat it.
Just curious, what's your prescription for protein intake here?
I think it depends also on activity level that we're talking about, right? And also other disease processes. So for example, if someone is having an average amount of activity, right, maybe they can get away with 0.8 grams per kilogram. If they're pretty active and exercising throughout the week, maybe 1 to 1.2 grams per kilogram. I think for bodybuilders, it's very different, right? It can be much higher, and for example, someone with kidney disease, it may be much lower, right? Maybe 0.6 grams per kilogram. So it really depends on the patient.
Yeah. Context over content. All right. Let's talk about muscle loss. So I don't know if you know this. I know our mutual friend is a physiatrist. So there are two buzzwords in physiatry, right? So there's disability and there's function. I guess supposed quality of life is a phrase as well. So we're big on that, right? So we're all about performance and function, as you've already gathered from some of the questions that we've asked. And
So
what's that?
I'm learning too. So you teach me.
So one of the concerns, a big concern about this, is the fact that people are losing weight so rapidly that they are losing lean body mass. So much so that there is almost an arms race of both Eli Lilly, Regeneron, all these companies looking for what Dr. Mike Israetel, non-anabolic performance enhancing drugs. And it's an interesting area. How do you think about that when you're counseling the patient, when you're monitoring? I know you talked about DEXA has its limitations, but how frequent? I really want to get a sense of where you are with that. And do you have concerns like I have concerns?
So I will say, with or without medication therapy, for every pound you lose, you're losing 1/3 to 1/4 muscle. I think, again, it goes back to that contract, like these are medications. I think what happened is when there was a burst of popularity with these medications, some of these medications were being acquired through other means, telemedicine platforms, third-party platforms, maybe not even seeing a physician, maybe a text messaging service and acquiring these. There was also non-FDA approved drugs that were also being sold on the market. I think that's tricky, right? When you're having maybe let's say you're getting the FDA approved version of a medication, but you're not getting the appropriate counseling, you're more at risk, right, for muscle mass loss. I think also what we were talking about, individualizing that titration, right? What if you don't need to move up on the dose and now you're losing more than 2 pounds per week, right? You're putting yourself again at risk for losing more muscle mass. And so I think these things really need to be taken into account, go low, go slow, right? When it comes to medication therapy, make sure you're getting your appropriate protein intake, make sure you're getting enough strength training in. Strength training is also a big hurdle. When I see patients coming in and they're already very intimidated sometimes by the whole journey, right? It's a lot of information. It's a whole inflow of information. We go slowly, but can you imagine never having maybe been in a gym or a weight training room and not knowing how to use a dumbbell or even where to start with some of these exercises, right? And that's really a concern, right? It's a lot of resources also that people have to acquire. Maybe you're paying out of pocket for medication therapy. Can you also afford a trainer? Or maybe is it you're watching YouTube videos or maybe you're getting the medication through insurance and paying for a trainer, right? There's so much involved. There's so many variables, but I think the most important thing is trying to give your patient the best plan of, we're going to go low with medication. We're going to go slow. We'll go up when we need to. We're going to monitor the amount of weight you're losing on average per week, hopefully. If I could do it my way, I would love to get a body composition before every dose increase and track them from the beginning and every so often that doesn't quite always happen. But at least, if I can get it every 3 months, 3 to 6 months, that's good. Not every person has access to a body composition machine at their office or their institution. That's another thing. Sometimes people might send their patient to a gym, right? Or maybe they have a home scale, a home smart scale, right? We don't know if that's a medical grade one. We have no idea, right? So these are all different. There's so many variables, right? It's quite complicated, but we do our best to try to help preserve that muscle mass. Now, if you look at the medications generally, they'll say that the medications lead to more fat mass loss than lean muscle mass loss. But what we're really looking for is to actually preserve that loss of muscle that we see. Now, there are medications, like you mentioned, that are going to be in the pipeline, or are in the pipeline rather, I should say, and maybe many more to come, that are looking at potentially not only preventing muscle loss, but also helping with kind of that body recomp, maybe even helping gain muscle, right? So I think it's going to be, again, an interesting landscape. We're looking at things that really depend not only on quantity of weight loss, right? So how much more do you think of losing maybe beyond 30% body fat is important, or how you're losing it, or if you're sparing muscle while you're losing it, which thing is important? Maybe we don't need more than 30%, right? Weight loss with these medications, but maybe we need better focus on quality. It's just different, right? And I think both things are being worked on, right? We have medications that are being looked at that do lead to 25, 30% weight loss, but then we're also looking at how do we improve the quality of the weight loss that we're seeing. And we want to protect the muscle, we want to protect the bones, right? We want to do all of these things and really give our patients the best chance of having good quality of health while they're engaging in these journeys.
Yeah, no, it's well said. I just want to piggyback off of one point that you made earlier. I know you know this, but for the novice listener, so we're talking about 2 pounds per week. If you're somebody who has 50 pounds to lose, earlier on, 2-3 pounds a week might be okay. But when you get to that maybe last 15 pounds, now all of a sudden 2 pounds is too much, right? So there is a point of diminishing returns in terms of losing body fat and trying to keep on as much lean body mass. I read, while just kind of reviewing some of the notes earlier this morning, I read this opinion piece on Medscape. I'll send it to you because I think you'll find it interesting, and it builds off this discussion where in a gastroenterology journal, they were talking about what we're looking at right now is quantity of muscle, right? And again, the best way that we have outside of MRI and some of these imaging modalities will be a DEXA scan. Now, what DEXA is not great at, it'll give you a lean body mass, but lean body mass is everything but fat. So it's organs, it's water, it's even intramuscular adipose or intramuscular fat. And I have to credit Dr. Gabrielle Lyon for this because she's actually been talking about this. That's the first place I heard it. She's talking about this concept of myosteatosis. So the intramuscular fat content is really important because that dictates the quality of the muscle. They also talk about it in here, and we'll link it in the show notes for people, that you have microvascular blood flow within the skeletal muscle. That's super important. The insulin sensitivity, you've talked about this already. And then people have heard about this buzzword, mitochondrial efficiency, because that'll dictate the function and the oxidative capacity and how your body handles energy. And some of the stuff that they talk about in there, they're basing off of rodent studies. But when we talk about intramuscular fat content, this is something that has been looked at. In fact, I think it was the SURPASS-3 trial when they look at a sub-study of tirzepatide. And what they did is did an MRI on a lot of these individuals with type 2 diabetes, and they actually noted that within the muscle, the fat content within the muscle had reduced significantly, suggesting that even though your muscle mass is lower, it's still healthier muscle. The challenge is how do we assess for that? We talk about not having DEXA scan. You're not going to be getting MRIs, certainly.
Yeah.
So I did come up with a little framework. I was like, okay, what does muscle, like what is it responsible for? What are the components? So I thought that, bear with me here. I thought that, okay, we could have a structural component to that, right? Mm-hmm. So this is what we could look at, CT, MRI, but in my clinic, ultrasound. I have that readily accessible. So I'm actually going to start doing this when I prescribe it, right? So I'm going to get muscle thickness, particularly for some of the vastus muscles, the quad muscles and your gastroc muscles, and maybe we'll do brachialis for upper extremity. And then you could also look at ecotexture. So how, for those who don't know, how bright and signal it is, it'll suggest how much fat content is within the muscle. You have to be a little trained of a sonographer to have an eye for this. And then there's a functional component. This is things that people could do by themselves. We're all seeing so much out there being talked about the role of grip strength and its role in longevity. And so that's something you could test by yourself. You could certainly do 3 to 5 rep max testing, dynamometry. You could check gait speed, 6-minute walk test, all these kinds of, pick your thing that you want to check to start off with. And then last but not least, the metabolic component of muscle. So insulin sensitivity, some of that's going to come from the blood markers that you had talked about. But I think that VO2 max, if you can get somebody, again, this is a lot of work. So I recognize that not everybody's going to want to do this. The patient like me would want to do this. Maybe
the ideal construct.
What's that?
The ideal construct.
The ideal construct. That's right. We're all optimistic here. Maybe someday. But I think VO2 max is good because it's a good integrator of all these things that we talk about. And so I think that's like something that was really cool about it. I even learned today that there's a trial registered called GRAMS, where they're actually looking at specifically examining GLP-1 based weight loss and the musculoskeletal outcomes, bone muscle function. So that's going to be a couple of years down the road. But I think this is such an important area. And again, you can see why it really matters for us.
Yeah.
Darsh, we were talking about earlier before he jumped on, like he's in the skilled nursing facility. You're seeing people in their 60s, 70s, 80s. Oh yeah, obesity is bad. You know what's worse? Sarcopenic obesity.
Yeah.
Way worse. And that's where I have the pause. And so that brings me to this really important question that I want to ask you. I'm almost scared to ask because I know the people in the comment section are going to destroy me. But is there ever a time where you think it's appropriate to, quote unquote, cut a patient off this medication, right? Where you've had that conversation that on your initial consult, you've talked about, hey, listen, the foundation of this pyramid is lifestyle things that we talked about as all these things. And yes, this is a tool, but like any tool, like any medication, they can be abused, right? And they're not doing the things. I mean, there's no way for you to for sure know, but you see this person, they're coming time and time again. You are clearly seeing them have, they have lipodystrophy and they are looking like they're losing a significant amount of lean body mass. And maybe you do have some measures and they're just talking about going up on the dose, or you're like, I think we should go down on the dose because we've had too much rapid weight loss. And you recognize that, hey, maybe I'm treating something more than just obesity at a physical level.
Yeah.
What do you think?
There are some things that you need to definitely watch out for. And I think sarcopenia, you're right. It can be dangerous, right? And it really depends on how you're prefacing this, right? I think you want to make sure that your patients understand this from the get-go, that, we hear about all these things in the media, right? Ozempic face, Ozempic butt, Ozempic finger, Ozempic hair, right? I tell all of them, listen, I want you to reach your weight goal, but I also want you to help improve your sugars, help your insulin resistance, help everything. But I want you to, being thin is not being healthy, right? I want you to be healthy when we reach this. And it's really important for you to maintain your muscle mass. Muscle is also the largest metabolic regulator in your body, right? And I talk about all of these things from the beginning. I think imparting that education at the beginning and going at each follow-up and following up on these things is really, really important. And that's why it's not a rat race, right? To go up to the highest dose and hit the bell and then you're done. That's not how this works. And that's why I tell all my patients that too. Some of them, you're hearing so much from Reddit, Facebook, the news, your girlfriend on the street who's lost 60 pounds in 2 months and people think it's great. And I'm like, no. We're aiming for 1 to 2 pounds per week, maybe even more in line with 1 pound per week because we want a greater fat percentage loss and muscle mass loss. These are things where you really have to spend the time and educate people from the get-go so we don't have that train being derailed in the wrong direction. Now, I also tell people, why do I have certain questions on my intake form? Like, have you had disordered eating disorder? All of these things, because we want to make sure that patients are safe while they're engaging with these medications. You want to make sure that we're not converting one eating disorder to the other, right? And we need to screen for these things. Right. And I think that responsibility needs to be there. And that's why we tend to be very wary of places that hand out these medications without any counseling, without any structure. I think it's really, really important. Sometimes patients will go, Dr. J, can we do this a little bit faster? Can I not push this up a little bit? Right? It's really important. Again, our patients are really, really smart. They're really smart people. Yeah. We can tell them like, hey, remember tortoise and hare? You don't want to go so quickly. You want to go at an appropriate pace. So you come out of this looking great, feeling great, being healthy. Right? And again, I keep driving home that point because I really, really think that if you're spending the time to educate patients on why we're doing things a certain way, the conversation is very, very different. I think we also just have to do our part as clinicians from the beginning and really spend time with that education. There are people that you're going to see coming in potentially with disordered eating disorders. Not even potentially, definitely, you will see these people in the patient population. You may even have patients who engage in too much exercise, right? Things like that. So you may see some of these things and you need to always take a step back and tailor that with patients, right? Be like, hey, I don't think we're meeting our protein requirement. Let's focus on this a little bit. Let's see how we can engage better in this. But there may be a time where if you need to have the conversation with the patient, like, hey, I think we should scale back a little bit, take a break. Maybe, we need to reshift, redirect the conversation. I think that's okay. It's very individualized. But I think if we do it from the beginning, we can maybe, get ahead of reaching a point where they're there. I always tell them, I joke around with my patients sometimes that I love my derm friends, but I don't want to send you there for extra Botox because you're getting Ozempic face, wrinkles and looking gaunt and by losing that elasticity or having too much hair fall from losing the weight too quickly and not getting enough protein, getting brittle nails. And I think it's really important because when they know why you're saying it, they're going to pay extra attention to it. I had a patient who very humbly reminded me, why do you ask me about weight training every time again? And it made me click, I asked the same 5 questions, but they forgot why I'm asking them. So let me go back and tell them why I'm asking. So we need to listen to our patients also and remind also and reiterate also, right?
I got to ask this as well. So a lot of times my patients have a tough time getting in to see their PCP upon discharge. It'll be like a month, it'll be 6 weeks. So we kind of have to fill the gap there maybe with a telehealth service. But of course, with these patients, they're going to be on blood pressure medications, possibly things for hypothyroidism, whatever comes with chronic disease. As they start to lose weight, one of the danger zones that I tend to find is they're going to have to decrease some of these medications. How do you think about that? Are you in communication with a lot of the primary care doctors? What are the things that you tell them to watch out for?
Yeah, this is definitely something that we grappled with, right? I think a lot of times we operate in very siloed systems, like this is my lane, right? But I say, as an endocrinologist and obesity medicine specialist, I may have spent years training to specialize and I'm despecializing, right? I'm literally despecializing because I'm taking care of so many systems that are metabolically involved, whether that's blood sugars, cholesterol, the liver, right? Also like contributing to their heart health, like every organ system is related. And that's kind of goes back to what you were saying in the beginning about working with every specialty practically. I work very closely with sports medicine, orthopedics, and PM&R as their official endocrinologist because we're working together all the time. But I've also lectured for psychiatry and also all these other specialties. And it's because it's really the teamwork that has to be in play here because we're taking care of the whole body system essentially. So you're right, as the weight tends to decrease, some weight-associated conditions can also improve and maybe require less medication. And a lot of times, I'm coordinating that care with the primary care doctor or the other specialist or monitoring it myself also and just finding, hey, the blood pressure is starting to get better. We might need to go down on this dose soon or just flagging this for you. So that communication is there. A lot of times I'm seeing the patient more often, right, than the primary care physician because I'm seeing them every 1 to 2 months. So I also need to do my part and communicate with them, but also tell the patient, hey, you need to flag this to your physician. And it's always better to do it a little bit ahead of time, right? We're not in a place where we're pressured, where we're like, oh, wow, your blood pressure is very low and you're feeling dizzy now and we haven't backed off your medications. So it's really, really important with these medications to also titrate other medications. We see that a lot, whether it comes to blood pressure, cholesterol, even thyroid medications.
Yeah. When people ask me what my specialty is, I'll answer by saying I'm board certified in sports medicine and PM&R, but I'm in the business of helping people. And I think a lot of folks, if you're truly in that business, I mean, so many times I'll have a patient, they'll come in for knee pain and they'll say, I have this situation going on and I can't get in, or, can I talk to you about that? And I was like, yeah, sure. And the challenge for me has been when I've reached out to the primary care doctor once or twice and they're not doing something, it's okay, how do I stay in my lane, right? Because that wouldn't be a thing if everybody's putting patient first. That's not a thing. Like, we don't have lanes. The patient has a lane and we're all walking in the patient's lane. But on that note, so earlier we were talking about counseling, putting the patient first, patient-centric approach to this. How do you think about these med spas, a lot of locations where they've popped up and they're not having that conversation? And I think this is where this struggle has been, this tension has been with compounding pharmacies, pushback, shortages, where a lot of these clinics were, these medications were so readily accessible. They still are, actually, because they've changed like a little, added something to that. So it's no longer the exact same drug, tirzepatide and so on. And these patients are not getting all the extensive counseling, the education that you've talked about. They don't necessarily have somebody who's looking out for their best interests. They have somebody who recognizes how lucrative of a business this can be. What concerns do you have with that?
I have a lot of concerns because these are medication, right? So I think again, I've had a lot of patients coming in from third-party platforms, right? And sometimes they're coming in because they're having complications, right? I've seen some pretty drastic things happen. I think people don't realize how something as simple as constipation can go to hemorrhoids and potentially go to an anal tear, right? I have literally seen some of those patients who have come in from third-party platforms and had severe complications, or maybe having incessant vomiting and not getting care, right, at the appropriate time. These things can be dangerous, or having kidney injury. A lot of things can happen, right? Or not counseling the patient on potentially like acute gallbladder disease or pancreatitis. These things need to happen along the way. And it's very, very dangerous. Again, I always educate patients. We had the FDA come out with warnings. We had Novo Nordisk come out with warnings. We had Eli Lilly has come out with warnings about making sure that you're using FDA-approved medications and not drugs that are non-FDA approved with the same name, right? I think it's not all at the fault of necessarily the patient. You have to see also how some of these are marketed, right? They don't say that they're not FDA-approved medications. Sometimes the patients think that they're on the FDA-approved version, right? They don't know that this comes in a pen, not a vial. And now Eli Lilly has vials and they have vials too. And it can be confusing for people. Or patients may not realize that there's any difference in the quality or safety metrics, or the fact that those aren't studied and the dosages aren't the same, administrations maybe not the same. There's so many differences. And again, I think it comes down to a lot of responsibility, because patients are really trying to look out for themselves, but there might be a lot of barriers. In the beginning, it was supply. It's also cost. Luckily, industry is trying to bring down that cost. We started somewhere with some of these medications being $1,500, $1,600. Some of them were $1,000 to $1,200. And now we've come down to oral medications being at $149 per month for some of the lower doses, up to, maybe $299, and the injectables being at $199 up to almost, I think $499 or $449, about like $500. So it's definitely come down, but that's not the whole scope for everybody. Maybe they can't afford that if their insurance doesn't cover it. But at the same time, I would say there's also been studies done on some of these drugs which are non-FDA approved, and there have been reports come out that there are up to 30% impurities in some of these. And so it's really important. I tell people, like, I don't know if I would recommend that to my family member, right, to take, because you might be shortchanging finances for your health. The FDA has reports about serious adverse reactions with compounded drugs, hospitalizations, deaths, right? And some people may come back and say, oh, you're just saying that, industry wants to make a profit, but those people who are selling this to are also making a profit. So I tell my patients, everyone has an agenda, right? But you have to be the biggest advocate for yourself, right? Everyone is there, maybe at a job, trying to make money, doing whatever. We all have to earn a living, but it shouldn't be at the cost of your health. And that's what I try to tell my patients, that I really want you to kind of view it in that lens. And we can't forget, we do have medications that we used before GLP-1 came out, right? And that's where some of these medications come into play. And maybe if it's not possible for you to get one of these medications, then we use some of those other medications that we had, right? In conjunction with lifestyle changes or plus or minus bariatric surgery. We still have other options. We can't forget we have those other generation of drugs that we used before this as well. So there is utility, right, to going back to some of those. Yes, do we want everyone to be on creme de la creme, absolute wonderful medications? Yes, but there are barriers. There are definitely barriers still, and it's a work in progress. I think with expanding indications gotten a bit better. I think with prices coming down, that's gotten a bit better. I think with supply chain coming through, that's gotten better. I think with orals being out, that's also gotten better. So I think it's definitely heading in the right direction, but we still have battles, like how you're saying, some insurances dropping coverage. And we're left as providers to kind of bridge that gap. So it's tough. It's tough.
Yeah. So a lot of this discussion obviously has been about weight loss, obesity. There's been talk now about, we talked about the central pathways too and how it can trigger the brain. So tell us a little bit about addiction. I think that's one of the topics now that they're starting to maybe look at. Every generation has its own vice, but we know gambling has become something that's huge now, especially sports gambling and poly markets and all these things. We're seeing a lot of people starting to really just get addicted to this, different things, but gambling being one of them. What do we know about how these medications can help addiction?
So actually, we started seeing this in clinical practice where people were saying that they were potentially drinking less, smoking less, engaging in less, maybe compulsive behavior like shopping or gambling or nail biting, things like that we were seeing in the clinic, which I think really cued in people to also start studying it. And there are studies that are being done for addiction, whether that's tobacco addiction, alcohol use disorder. These things are being studied for these medications. There are also other things outside of the scope of weight management that have either been looked at or are also being studied. For example, there have been studies with semaglutide and heart failure. There have been studies with semaglutide and kidney disease. There have been studies with semaglutide and knee osteoarthritis. And I think there are also studies that are being done for other disease processes with these medications, including PCOS or polycystic ovarian syndrome, right? So they're really expanding into other arenas because I think we've also been cued into the fact that there are some medication effects that we quite don't know the mechanism about, right? Is it because they're decreasing inflammation that it's helping with some of these things? So I think these things are being investigated more and kind of based off what we're seeing in clinical practice as well. And also from preclinical studies. So all of those things.
I know previously when we had spoken, you had mentioned PCOS. That's another one. I think I was excited to see that there is a trial underway at this point looking at that specific population. However, there are a lot of people who have talked about, PCOS and how these medications can be an absolute game changer. Now, this is an area of interest for you, and you think you had mentioned that you're doing this a lot and you're using it technically off-label still, correct?
If you have, for example, you're living with overweight or obesity and you have a weight-related condition, right, and it's applicable to you. So it's not necessarily that I think it can be applicable to you, but I think what you're talking about is it being a primary indication for PCOS as opposed to a secondary way of looking at it.
Exactly.
There's no primary indication for it yet, but we really have 3 medications that we use for PCOS right now for different pathophysiology related to the disease state.
I took this for granted. Can you just explain PCOS for the person who doesn't know what that is? I just use that liberally, yeah.
So polycystic ovarian syndrome is, in short form, PCOS, and it has a kind of scoring system to meet the diagnostic criteria, Rotterdam criteria, where you need 2 out of 3. Right? So you can have irregular menstrual cycles, right? And there's definitions of maybe having your period too frequently or less frequently, skipping months, and also having another feature of potentially having cysts on your ovaries, and another criteria where you may have elevated, for example, male-centric hormone levels like testosterone, or have symptoms of that, right? So excessive hair growth, acne. So you need 2 out of 3 of those criteria, right? And a lot of medications that we use target different things in the pathophysiology of this disease process, which also we don't know a lot about, to be honest. There's birth control, there's metformin, and then there's spironolactone. And these were the 3 things that we kind of used to deal with different sequelae of this disease process. Now, with the GLP-1s, that's been a little bit different in practice that we've seen where people may say, you know what, my menstrual cycles have improved. And we don't know if that's quite a construct of maybe what this medication is doing, if it's acting on inflammation, if it's acting on the ovarian dysfunction, if it's doing something else, we're not quite sure. Or if it's related to weight, and because weight can also affect menstrual cycles, vice versa. So we don't know where that's really coming from, but that's something that I think will be studied, or potentially should be studied or investigated. And so a lot of endocrinologists, we've seen that in clinical practice, our patients living with PCOS have done really well on these medication therapies. Because a part of PCOS is also insulin resistance, right? And they are also very susceptible to metabolic syndrome, pre-diabetes, diabetes, high cholesterol, weight gain. These are things that a lot of our patients struggle with when they're living with PCOS.
Thank you for that. Before we get into kind of the future direction and what we're going to see next, I'm very curious to just get your take, because you can go down different avenues just with the philosophical stuff behind GLP-1s. Is it cheating? Is it not? Willpower, talking about the food industry as a whole. But let's stick to, why do you say this is not cheating? What do you tell patients? What do you tell the public who say, it's just a lack of willpower and these patients should just work out and eat less?
I think it's biology and not blame, right, that we're looking at. I think we just talked about a disease process which predisposes people to metabolic syndrome, right? PCOS. Patients may be living with other medical conditions that may make weight loss very difficult, right? And it's not their fault. Nobody asks for PCOS, like, please give me PCOS so I can struggle with every metabolic condition, right? Nobody's asking for a disease process. Nobody asks for surgery. Nobody asks for medication. But if you have a real medical condition, such as overweight, obesity, right, or anything else, you should treat it, right? And maybe one method of treating it is not working, and then it's important to redirect and reframe that conversation. What else can we do to help better that medical condition, right? And make sure that you don't have worsening medical conditions along the way. And that's how I kind of restructure that. I think we have a lot of bias in the community. There's a lot of weight bias and stigma. And there's also now stigma for people who are using these medications to treat the disease process. So it's almost like you're damned if you do, you're damned if you don't. And I tell individuals that it's not a failure. It's absolutely not a failure. I don't think we would tell anybody if their cholesterol was too high and they're on cholesterol medication that they were a failure. That's not the. So why should we do that with weight management? And I think when, oftentimes I've seen with people, if really preface it that way, it's the first time maybe they're not experiencing that judgment. I have patients that come into the office and they cry in my office because healthcare providers have either judged them, not listened to them, not believed them. And it's extremely traumatic. And so sometimes I have patients who are coming in who actually probably exercise and follow a better diet than even I do, right? And they're still unable to achieve what they're trying to achieve. And that doesn't mean that they're doing something wrong intentionally. It may mean that they have something underlying that's contributing to that. I think it's really important for patients to know that it's not their fault.
Yeah, I want to just chime in here on this one because I think it's such an interesting thing. I forget who I heard it from, but I did hear in Modern Wisdom with Chris Williams and somebody talking about it might not be somebody's fault. And when we're thinking about blame and responsibility, if you have a situation where you've been dealt, bad hand, when you got the PCOS, right? You got some genetic predisposition where you have, I'll use myself as an example. I have my Lp(a) is through the roof. Do I go yell at my parents about this? And so no, that is not your fault, but it is your responsibility. And I think we need to disentangle those two things together. And of course, you've highlighted at length about that intake process and counseling and education over and over again, and why it is their responsibility and they have to take agency of the situation. And to steal something from Dr. Nisha Chellam, a previous guest, is she likes to tell her patients, hey, listen, you're driving this car. I'm sitting in the passenger seat with you, right? And I'll tell you where to go, which directions, and to apply to this context here is we'll prescribe the medication. You can empower them with the knowledge and the education, but they have to apply that, right? They have to implement the resistance training, the sleep habits that you talked about, the overall stress regulation, that kind of stuff. And if they're not going to do that, is going to be very challenging if long-term health is the goal. And I don't know why there's so much discourse for that. Can we not disentangle that? So I think that we probably can hold the both truths that, yeah, it's not somebody's fault and we don't want to blame them, but it could be their responsibility. What do you think about that?
I think that's fair. You know, if you want to say that your health is a part of your responsibility in terms of keeping yourself healthy, I think that's totally fine. But I think we're still living in an era where people are blamed for what is a real medical condition. And to me, that is more jarring, you know? It's really shocking to me, some of the things I hear and some of the things I see. And they can be very basic. It can be something as, I had a patient, I remember, they told me people were behaving differently after they lost weight. And just to wrap my head around something basic like that, wow, really? And they were like, yeah, people behave very differently with me after I've lost weight. And you have to hear about some of these day-to-day experiences that people have, you know, with weight bias and stigma. And so sometimes it may be that even if health may be a part of responsibility or whatever we may say, maybe they don't feel safe enough. Maybe they don't feel comfortable enough to ask somebody for that help because of the experiences they've had. I remember I saw an individual who was just like, I am too afraid to even go to the hospital because everything is blamed on my weight. And that is a very sad, that somebody doesn't feel safe enough to go receive care because they feel that they're going to be blamed. So sometimes the construct that we're in, whether that's internalized bias, explicit bias, implicit bias, it can really affect on how people may feel safe enough to even take those first few steps, which may seem very basic. I think even just signing up for a doctor's appointment means that you've had a lot of thought about something, right? You're there because you want to get help.
Yeah. Did you see the Eli Lilly commercial this weekend? I don't know if you're watching any football, but that's the new commercial that came. That's what it was all about, right?
I didn't see. Is this a new one?
Yeah. I mean, the first time I saw it was this weekend.
What was it like?
It was a person who, I think he was just saying, he's like, yeah, you can continue asking me about my workout routine, and you can keep judging me. You can be in the comment section, but I'm gonna be focusing on the things that matter the most, like the people that I care about, getting how I feel when I get up in the morning. And then it's like he has a very dismissive attitude towards quote unquote all the haters. And it's just zooming like out and from dark to light. And you see this person and, you know, looks like he's overweight for sure. And then it just says Lily. I forget what like the tagline was. You must know Dr. Melanie J, right?
Yeah.
She's in weight. Yeah. I'm her TEDx talk. I had seen this a long time ago. I think she talks about this. We'll link it in the show notes where she talks about the experience that I think shaped her into going into this field, where a patient in the emergency room was dismissed and they were going to be discharged, and not long after the person was maybe in sepsis or septic shock. So we'll link that for people to watch it. It's like a 10-minute talk. But yeah, I couldn't agree more. Sorry, Darsh, you were going to say something there.
No, I was just going to talk about Drug Story, that podcast. I don't know if you got a chance to listen to it all too much, but Priya, there's a really cool podcast that just came out from a journalist, Thomas Getz, I think his name is. It's called Drug Story. And so each episode just goes through a drug, and they talk about essentially the origin stories, its effects, and its side effects, and kind of just the big data around it. And the latest episode was actually on GLP-1s. But it was just really cool to see even Getz's take on how, when he interviews people, everything you're talking about, from the judgment to the blame that goes on people, to shifting the blame actually on food companies. And so we had David Wiss on this podcast some time ago talk about food politics and just how dark it can get when you actually look at who's owning these companies. And a lot of it's actually the tobacco companies that now are owning these food companies, and they have the marketing down to a T with these ultra processed foods. So I've definitely been even shifting my biases, I guess I can say, more towards, blaming kind of the industry for making us addicted. And it's hard to get out of that loop when you're surrounded by it everywhere you go. You'll have drug commercials, then you also have commercials for fast food restaurants. And it's a question of how do you disconnect from almost the world around you, in a sense that's trying to pull you toward these things, but how can you leverage your authority almost over these companies? How can you beat them? Yeah, it's a tough thing.
Yeah, I'll say two things here. So when I initially joined NYU, when I was helping build the clinical care pathway for obesity medicine, I did that alongside Dr. Holly Lofton, who's the weight management director there. And, we had gotten a grant to actually develop a OSCE, which is actually a training tool that we use for trainees in medicine to teach about weight bias and stigma. And that was the first time they had that at NYU, where we really got to teach medical residents through a practice exercise with a standardized patient about weight bias and stigma. And it was it seems very basic, but it's such a vital skill to have, because especially with these medications that have come out, do you know how to start the conversation about asking somebody if they're okay with speaking about their weight? Is it okay that the patient didn't step on the scale? Teaching these basic things that we don't need to force the patient to step on the scale for taking vitals, right? How to have first person language. All of these things are really important for physicians that are entering this field, any field in medicine. I think any healthcare provider, not even just physicians, any healthcare provider, any person who's working in healthcare should really be equipped with this knowledge on how to combat weight bias and stigma.
Do you have a quick 1 minute framework that you use? So I would love to hear that too. I mean, I would love to talk about this with my patients, but sometimes I tend to hesitate because them being in a rehab, they think I'm asking for a certain reason. So how do you actually open that conversation?
Yeah, I think for me, it's a little bit different because everyone who's coming to me knows why they're coming in.
Right.
But I think it's really important there is actually a framework of the 5 A's that you can use. I think something as simple as, are you comfortable with discussing an aspect of your healthcare, which entails speaking about weight management? Can you tell me a little bit about your weight journey? Would you like to focus on weight management today? And if someone says no, that's fine, right? There's no need to press on it. Or we can go about it a different way, right? Let's say the patient's coming in with prediabetes. You can talk about their blood sugars and say, another thing linked to prediabetes is sometimes we can work on weight management in order to help your blood sugars. Do you want to talk about that today? And I think just asking the patient, but also reframing how we're speaking about patients even. So instead of writing obese patient in the chart, the fact that patients can read their notes now is also important to not write that, right? We don't write hypertensive patient, right? Patient with past medical history of high blood pressure, living with obesity. Instead of using that appropriate language is also very important. Making sure you have appropriate equipment in the office, appropriate blood pressure cuff, an appropriate chair. These things are all really important to create a good environment.
Priya, what's the most important thing that we haven't talked about today that we should have talked about?
Not that it's the most important thing, but I think there's so much to talk about. So maybe we'll have to do this again. But I think one thing when we were talking a lot about muscle, bone, we didn't really get to dive into some of the other medications that are coming out, maybe even the ones that are surrounding amylin, right? So amylin analogs that are coming out. And there's also other hormone receptors that are going to be targeted, right? So we see, for example, glucagon coming into the picture, being combined. We hear about triple G coming out.
That's retatrutide, right?
Yeah, so a glucagon, GIP, GLP that is being looked at. And so there's a lot of different mechanisms that are on the horizon. But I think the one thing that we did touch upon, I think in addition to all of the things that we talked about, I think the most important thing is really treating your patients with care and respect, making sure that we're being very mindful of the weight bias and stigma that they may be coming to you after experiencing in the world, and really treating them with the care and respect that they deserve, and making sure that we know that these agents are medications and patients need the appropriate counseling and follow-up to stay on this medication therapy for a chronic disease process. I think those are the most important things, which sound very basic, but they're extremely important.
I love it. Priya, this has been absolutely incredible. It's been better than I had hoped that it would be. And I think my favorite thing that you've said today when we've asked a question is, it depends. To steal something from Joe DeFranco, he's a famous strength and conditioning coach. He says, everything is application and situation specific, right? Good advice for the same person at the wrong time or a different time can be bad advice. For a different person, different situation can be bad advice. So I think that nuance that we had talked about is so important, especially for a topic as sensitive as this, as important as this, as pivotal, especially in this moment. I think there's a lot of hype, a lot of merit. And I mean, you did a phenomenal job. So I really do appreciate you, and you've been generous with your time. So thank you so much. How can people connect with you, socials, that kind of stuff, if they want to reach out, if they want to come work with you? You're at NYU, you talked about that. Where can they connect with you?
Yeah, absolutely. So I am on a lot of media platforms. So you can find me on Instagram, Dr. JNY. You'll also find me on X. You'll find me on LinkedIn just by my name. And of course, you'll find me on the NYU website. So I'll be there as well. And you might see me on your TV occasionally on the news. So that's also there. But very happy to be here and to talk about this. Thank you both for inviting me. Truly was a pleasure. We had a great conversation. And I hope your viewers learned something from this and enjoyed this conversation.
100%. I mean, I definitely learned something. And again, we told you we were excited about this and it was well worth the wait. So thank you so much. Our last question for you is, how do we put the health back in healthcare?
I think we have to shift blame to biology. We need to shift from blaming to looking at the biology and treating obesity as a disease process and really showing empathy and care and using efficient tools and treating the whole person, right? So I think that's how I would put care back into care.
Love it.
Love it. Thank you, Priya.
Thanks, Dr. J.
Thanks for listening to another episode of Medicine Redefined. If you enjoyed this episode, please be sure to check out some of the additional resources in the show notes. Please also check out our social media platforms where you can find more content like this. You can follow us on Instagram, Twitter, and TikTok at MedRedefined. We also want to thank our team for the production of this podcast, specifically Ethan Ju on video, Harita Yepuri on social media, Zainab Lugmani on research, and Sarah Khan for newsletter. Oh, and if you want to get similar bite-sized information delivered to your inbox every Sunday, please be sure to sign up for our newsletter. Also, if you enjoyed the show, please be sure to subscribe, review, and share with anyone who you think will gain value from this as well. Now, time for the ever so important disclaimer. This podcast is intended for general public use and is for educational purposes only. It does not constitute the practice of medicine, nor should be construed as medical advice. No physician-patient relationship is formed, and anything discussed in this podcast does not represent the views of our employers. We recommend that you seek the guidance of your personal physician regarding any specific health-related issues.